Good evening, Namaskar. Welcome to Fertility Dost. What exactly is this PGT? Or we could talk about PGS. We all know that this PG means pre-genetic. Then again, why we are using S or T after that? Screening, testing. Is it really such an important topic that we on this platform should talk about it? Yes, it is. So when we discussed about embryos, we talk about the grading part. We just say, oh, is this day 3? No, 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 it's a day 5 embryo. Blast hai? Oh, ho. No, no, no. How many cells growth? So different questions, different inputs, different outputs, and ultimately what we really need a good healthy embryo so that it can be transferred successfully, and it could be what you say that implanted in your uterus and result in a beautiful pregnancy for you. And again, live birth is really important. So we consider these PGT is something that could help you achieve the pregnancy in better way. So today we'll talk about this. Yes, you must be thinking that without mentioning anything about doctor or city, I was just talking about this. What is PGS, PGT? So it's just a, you can say that highlight of the session. So, viewers, we'll discuss about this very important topic, PGT. Actual PGT, what is it? Do we really need to know more about this? And the knowledge of this proper testing or this technique could help us achieve pregnancy. And in case it's this test, or we can say that this technique is really a good one, then why not opt for this? And who are the candidate for this? करना भी है नहीं करना है छोड़ देना है many questions, many confusions. So we thought to call upon one of the very senior doctor from ART Fertility Clinic, Chennai. Yes, none other than Dr. Dakshyani with us. And when we talk about her, there's a this big smile on her face because she's such a wonderful person, such a I can say that wonderful, beautiful soul. She helps so many couples. And recently also we have very good input, very good feedback from one of our members उनके बारे में. So let's call Dr. Dakshani and start with the session. And we were so sorry for the delay because we have some network issues over here. Namaskar, ma'am. Welcome to Fertility Dost.
Namaskar, Purnima.
So, viewers, we have very senior doctor with us, Dr. Dakshani from. She's a clinical director of Chennai ART Fertility Clinics. And viewers, please do start pouring your questions with her. We'll discuss about the role of PGTA in recurrent miscarriages. Nowadays, we deal about these things. It's like we can say that traumatic thing when after waiting for 15 days we just got our levels to show that the result is negative, and after that we just think about what next, what to do we really need to change our doctor, do we really need to shift focus about other testing and all that. So we thought just call the senior doctor on our platform and discuss the things. She has more than 20 years of experience, so we just cannot think about other name for this particular topic. So
Thank
over
you
to
so
you.
much, Purnima. Thank you so much. Purnima,
And
today the topic of discussion is, as you rightly said, is about pre-implantation genetic testing or genetic screening of the embryos. Okay. So when we are talking, it is called PGTA now because we call it as pre-implantation genetic testing for aneuploidy. Aneuploidy is to know whether the embryos are chromosomally normal. Okay,
oh,
so this testing is very, very vital for people who have like been trying for pregnancy with various problems. It could be a primary infertility or a secondary infertility. It could be like they would conceive on their own, they have recurrent miscarriages. So we don't know the quality of the embryo which had got implanted. And there are patients who are like with difficulty to conceive had come to a fertility clinic. They had implantation failures, like they had one or two implantation failures. So even in those conditions, it could be the embryos which were looked good on the embryologically point of view. Our embryologist would have graded them as AA or AB or BB or BC. Like, but then the quality, the appearance is different from the chromosomal makeup of the embryo. So there are conditions where we had put in a AA or a AB embryo, but then we had a miscarriage of that because the chromosomes was not normal. So, when there is miscarriage, recurrent miscarriages, when there is recurrent implantation failure, we think that we are putting in a best embryo, and we know that her endometrium, the woman's endometrium was beautiful, her progesterone levels were optimal, but then we see that they don't implant. 15, I mean 10 days later, we check one beta HCG. 15 days later, we check one beta HCG. We are like, we feel sorry that the values were very low. So when we are seeing this sort of recurrent miscarriage or a recurrent implantation failure, or in other conditions where these days women come very late in life for seeking pregnancy. So by the time they come to a fertility clinic, we see their AMH level is very low, and the number of eggs we get from them and the number of embryos we could grow along with it is very less. So in those conditions also we see that abnormal embryos are more. So how do we identify abnormal embryos? It is only by the biopsy of the embryos, where the tropectoderm cells are taken by the embryologist. They do the biopsy, and the cells are sent for genetic studies. And the genetic studies will tell us whether the embryo is a chromosomally normal embryo and it is transferable. And we use only those embryos for transfer, and our success rates are much, much better. Those who had failed without doing this test and we had transferred them, they have a good chance of getting a positive after doing the embryo biopsy, checking the normal chromosomally normal embryo and transferring the normal embryo.
Okay.
So
So,
that is how it is going to help in our patients who have earlier failed with routine techniques like the routine IVF we do, IVF ICSI I do, when we recognized it as a good embryo and transferred it, but then it had failed. When we do a PGTA, we find out that it is a euploid embryo, and then only we transfer the embryos.
right. So, doctor, usually when we talk about this testing or embryologists talk about this, so people have this notion: is doctor going to harm my embryo because they are going to take something out from my embryo? So, what exactly is this?
True, exactly. Actually, what you said is very true. Usually, the couple, when they are coming for counseling, we actually extensively discuss with them what is the procedure done. It is I mean, we earlier we used to do day three embryo biopsies, where one cell from out of the few cells which are dividing it within the embryo is taken for testing. But now we are doing the day five biopsies, that is a blastocyst biopsy. So whether it was a day three biopsy or a day five biopsy, when a biopsy is done by a validated person who does the embryo biopsies, that is, our embryologists are validated to do these tests. When they do it, they actually don't harm the embryo. They take just only one cell from the day three biopsy, but now we do day five biopsy where only they take the tropectoderm cells. That is, there is what we call as an external group of layer of cells, and you have an internal inner cell mass, and the inner cell mass is the one which is going to become a baby. So we are only taking a few cells from the covering, that is the external rounded appearance, and those cells are taken and sent to the genetic laboratory, but the embryo per se stays in our laboratory only. So it is frozen and it is actually stored in our laboratory only. So we are not shifting the embryo somewhere from our laboratory to another laboratory and they come back to us. No, it's just that the cells are sent to the genetic laboratory, where the genetic laboratory will give us a biopsy report within a week's time, say, depending 4 days to 8 days they take in different laboratories. Commonly here, within a week's time, we get the reports. So after getting to know the report, then we stimulate the woman for her hormone, for her endometrium preparation, and then transfer the embryo into her. So definitely, the common man thinking is that the embryos can be damaged by doing a test, by doing a biopsy, but it is not so, because a good embryo biopsied and is thought to be euploid. When we transfer them, we have had so many pregnancies out of it, which were healthy babies.
Right. So, doctor, how you select a patient or how you select a couple that yes, they really need this genetic testing? So, what are the factors according to you?
Yeah. The Actually, the factors can be determined when we are seeing the couple during their treatment protocol. When they come to us for the treatment, younger couple, younger age group with good, like on the woman side, at a good AMH and good number of embryos, good grade embryos. If it was a first cycle, then definitely I would not be recommending her to go for a PGTA or any PGS test immediately. Okay, because I would think that transferring a healthy embryo is more than enough for her to get pregnant, okay,
Right.
with her age. But if a woman is coming to us with already a history of, say, one or two miscarriages
Hmm.
at 6 weeks, 8 weeks, or 10 weeks, whatever, if they're already coming with such history and we have ruled out other problems, like, for example, antinuclear antibodies, systemic lupus problem with them, and all those things has been ruled out, and we rule out something like the antiphospholipid syndrome, where miscarriages can occur. If we rule out them and we see none of them are positive, then it is always better that we think about the probable abnormal embryo which has been aborting all this time. So, in that case, even if she is a 28-year or a 30-year-old woman, and with an AMH, good AMH also, if there is recurrent history of pregnancy loss, ectopic pregnancy, and all those things, we will definitely advise them to go for a PGTA, that is
Okay.
the screening of embryos or looking for diploid embryos. Okay, so there are certain cases where PGTA or the PGT, we call it as, where there was a previous history. For example, a woman, she had her first pregnancy, she never had any problems, but then she was not diagnosed or detected for, say, Downs, or she was detected for Downs somewhere in the third month or fourth month when she did her when the screening test, that first trimester screening test. That couple is very anxious about her next pregnancy. She would want to know whether she's going to have a normal baby. So in those cases, we will definitely recommend them to go for an IVF program, do a PGT, that is, we do the pre-implantation genetic diagnosis of that particular problem which we had picked up. For example, it could be a Down syndrome baby the couple had, or the very close relative or a sister had had a Down's baby. So this person, because these are all genetic problems, so they will be very anxious whether they could have such problem also. Or it could be a muscular dystrophy, and a brother's child or a sister's child, someone, they were obviously normal up till the age of, say, 4 years or 5 years, and suddenly after that the child could not get up, walk. They was most of most of the time bedridden, like by say 15th year or 20th they lost the child also. So such histories, usually if there is any known diseases, then in that case also preimplantation genetic diagnosis or testing is very very important to rule out such problems. So these are some of the cases. Of course, apart from that, a very low AMH, a very advanced maternal age, if a woman is like aged more than 38 years, her chances of producing a good quality or a normal chromosomal embryo has already decreased. Like
Right.
we had certain tests which were done in some of the genetic testing centers, where they used to tell us 10 embryos sent at the age of 24 to 28 years. Out of 10 embryos, about 6 of them would be normal embryos. But
Okay.
say 10 embryos sent at the age of 30 years of age, out of 10 embryos, around 5 or 4 embryos would be normal, 6 would be abnormal. Similarly, about 8 to 10 embryos sent at the age of closer to 40, she will have only 2 embryos normal, 8 would be abnormal.
Huge gap.
So, with the age, this sort of changes do occur. So we have to accept that abnormalities do actually increase with the increasing age. Similarly, if there is a very low AMH, that is the ovarian reserve is very poor already, be it a younger woman also, her chances of producing an abnormal embryo is very high. So
Okay.
that is the reason now, like for the past 10 years, probably 8 to 10 years, we are regularly using this diagnostic tool, which has helped us save many people having too many recurrent miscarriages. And definitely they are like devastated. They're psychologically so like burnt out when such things happen. But now, even in cases like, for example, consanguineous marriage, very close relatives getting married. So in those people also, there is lots of chances that they have, abnormal babies. So doing a PGS test in that cases will be very useful for them. And
Right.
in certain religions they don't accept for donor sperms or donor eggs and all those things. So in those cases, even if they're going to get one egg or two eggs, they would still want to try their own gametes for the
Right.
embryo. So in those cases it's better that we check their embryos before we transferring it. So these are the cases where actually we do a PGS or PGTA to rule out aneuploids. That is, we don't want to put in any abnormal embryo inside the uterine cavity during the transfer.
Right. So this is really important that whenever you are visiting your doctor, please discuss your medical history or your family medical history with the doctor with an open mindset. Usually, we think that leave it. It doesn't mean anything to doctor to know about my family background or my family medical history. Plus, please make sure that you discuss each and every point related to medical history with your doctor. Doctor, if we have very low AMH, you just mentioned that yes, those cases also need this kind of testing. So I'll just take one query related to this. Just a second. See. So age around 33 plus, AMH is very low and going for first cycle ET. Does it requires to go for genetic diagnosis?
Priyanka, how many embryos you have, Priyanka? First cycle ET means how many embryos you're having now, frozen?
So you can write your answer in the comment section and we'll just take your question again. So doctor, we'll stimulation is going on, she's saying.
Okay. If stimulation is going on, depending on, because she's already 33 plus and AMH low, definitely she will be benefited with genetic diagnosis, genetic testing of her embryos.
So right
It
now she is having, sorry, around 5 to 6 follicles are there, she's saying.
then that means to say her follicles also are less. But if she is going to form good day 5 embryos, then at least 2 or 3 embryos, if she is going to have, then let her try, I mean, let her plan for a PGTA. It will be more beneficial. That she will surely know whether she's going to have a good quality embryo transferred inside her womb.
Right. So I think age is 33 plus, but again with low AMH, this testing
Yes.
will definitely
And look,
benefit.
her follicles also are very less in number.
Right,
I don't
right,
know her AMH value, but it says that probably her AMH is less than 1.
right. Because follicles are only 5 to 6.
Yeah, yeah,
So, doctor, when we talk about this, so she's saying AMH is 0.35,
yeah, it's very low.
very
For
low.
a 33-year-old to have that much of low, does she have, Priyanka, you had some endometriosis? Or did you do any surgery for the ovaries? Probably if she can come back with that, we could reason out why it is so low at 10. Because I think last time fertility those program also I was telling you that young women these days are like postponing their pregnancies. Look, these are the cases where I usually mention at 29 or 30 years or less than 30 years we have arranged donors. It is very difficult for us also, and that too with the changing art bill, it's even more difficult now. So it's better that women, especially younger women at the age of say 23 to 28, they should prefer to have their first child. I mean, what was followed a little few days before, few years before, or few decades before, I think that has to come back into practice for our young people to have a safe pregnancy and be less stressful in life.
Right. Doctor, if with this low AMH and advanced age, we are not getting day 5 embryo, then how to proceed further? Because then to we have no option for go for this genetic screening and all that.
I do agree. We can do a day 3 embryo biopsy also, but then only if there is a good quality embryos, only they do the biopsies. I mean, the
Okay.
embryologists also have very strict protocols which they follow. So only a day 5 embryo is supposed to be going for a biopsy. These days, non-invasive biopsies also, I mean, non-invasive genetic testing is also being followed. I mean, the fluid around the embryo, the cells are extruded into it. They study those cells and they give us the diagnosis. So even that method is being followed now these days.
Mhm.
But biopsy of day 3 and day 5 can be followed, but the latest followed now is day 5 only. So if you
Yeah.
don't have a day 5 biopsy, definitely we would not be recommending biopsies at all. So that means to say, if an embryo is not capable of going to day 5, how will it become a baby at all? It's
Right.
not possible. So probably in that case, we have to pre-treat the woman to see if we can improve her quality of eggs when we are collecting it, and do another cycle for her with a modified stimulation if possible.
Right. And doctor, do we really need to blame women for these genetic issues? Male factor also can contribute, or is it really for women only?
No, no, it we can't blame it completely on one side, but yes, the more of abnormal pregnancies can occur because of the oocyte factor. That is also true, But
Mhm.
sperm factors, the male factors, that is the poor sperms, poor morphology, or poor motility, all those things definitely are one of the reasons of development of a poor embryo. But commonly, more onus is on to the oocytes. If the oocytes are poor, then you could never get onto a very healthy embryo. But whereas now that procedures like in IVF ICSI, that is intracytoplasmic sperm injection, is being done, the sperm is sometimes just the sperm without much motility or without much thing, but then we see that good embryos are being formed.
Right, right.
What was required was just a healthy nucleus within it. Even if the sperms were not like swimming around very well, or they were not looking exactly the ideal sperm characteristics, but then they have produced good number of embryos, good healthy babies across the globe. But oocyte has to be more healthier to form a good embryo.
Right. So, doctor, we have one question related to this. If I don't have good number of day five blasts, then what? Then also should I proceed with PGS? Because there's this fear in the mind that if something happens, then my whole lot of my embryos, maybe they are two or three, they'll just destroy.
No, commonly, no. If there is a real indication, even if it is one embryo of day 5, we would subject it to PGTA to make
Okay.
sure that there is no such problems, that we are transferring an abnormal embryo inside the uterus and having either a negative beta HCG report, or
Hmm.
having a positive but then going in for a miscarriage again.
Right.
Okay, so that is the reason, if there is a real indication, we would want to do it even if it is one embryo or say 10 embryos. Okay, but if there was no indication, as I told you earlier, if it was a first transfer, there was no indication as such except for low AMH, or the age being a little on the higher side. If the couple choose not to do a biopsy, we would definitely respect their ideas also. But then we would tell it is better that we do a biopsy. But if they are not wanting to do it, we would not force on them. But if there are more embryos, probably the next set of embryos, if at all it doesn't happen to become positive or continue with a healthy pregnancy, then we would use the other embryos to biopsy them. But it would always be better to biopsy the embryos when they are fresh.
Okay, this is also an
Very
important.
important. Yeah, it's a
Right.
very important
So,
thing.
doctor, one question just for related to this fresh embryo you just mentioned. What if my doctor has frozen my embryos at day three, and they said that I'll just thaw them and just see the progress to day five? Then
We
should
do
I
it.
opt
Yeah,
for this? Okay.
yeah, we do. Many we do. Commonly, if there are good number of embryos, we all grow them up till day 5, freeze the best day 5 embryos. Or if we are transferring also, we might transfer one or two of the day 5 embryos, rest are frozen. But if there is some reason that we had to freeze on day 3, or we thought we wanted to freeze on day 3, or the patient requested us that they wanted day 3 freezing, we can do it, but we can grow it up to day 5 and then transfer. So many embryos we have done that way. They're still very good.
Okay.
That
And
is,
in that case, we can do this testing?
yes, yes, we can. We can.
Oh, right. So, like when we thaw them and when we just grow them till day five, and then we can do the screening testing, genetic testing, and then the transfer can be done.
Yeah, transfer has to be done again after a couple of days.
Oh, right.
Yeah, so we freeze again and then thaw it to transfer.
Okay. So, this thawing, freezing, does it impact the quality or growth of
No,
embryo?
actually, the laboratories these days are like doing an excellent job, and the freezing techniques also are very good. Freezing and thawing techniques are very good with very minimal sort of problems on the embryos, or they don't have any bad effect or ill effects on the embryos at all. So the thawing media which is used, or the freezing technique they are using, is all like sort of more of a globally used techniques. So your chances for the embryo to get destroyed or having problems is very, very, very minimal.
Right. So I think you just heard the right answer from right doctor, because we have this query that my doctor is suggesting that please freeze the embryos. We are going to freeze on day 3, and then we'll again thaw them and then take
Grow
them
it
to.
to day 5 is absolutely fine. Look, sometimes no, we thaw 4 embryos, we might end up having 2 good blastocysts, but that's okay, because when you're growing them, you know that the good ones only survive.
Right. And doctor, what about donor cycle? Usually, when we opt for donor cycle, there's some doubts in our mind that should we go for genetic screening, or should we just wait? Because it's always said that yes, if you are selecting a donor, that means we as a doctor giving you healthy egg. So, what you suggest in some case is
Yeah,
the donor case.
I totally agree with you, Purnima, because look, when we are taking a donor, because as I told you, now the donor, the art bill and the art law has all changed. We have to have one fresh donor who's donating only once in her lifetime, and those things, her identification proof, her Aadhaar thing, all those things has been followed to make sure that these things are happening. And it has to be legally, she has to be legally bound, and she has to have an insurance on herself, and all those things has to be made clear. And one more thing is, we make sure that we are taking a good history from her, to make sure that their family does not have any abnormal
Genetic issues.
anomalies in some of the children born in their families. But look, sometimes we don't know if they are giving us the correct information also. So in that case, when sometimes when my patients, or the couple who's wanting to have the donation done, when they are wanting to know more about these things, we do the tests which is necessary. That is, we do the screening test, we do the thalassemia screening, whichever can be done as blood test we can do. But then the embryos have to be checked only. So if the couple sometimes are a little bit apprehensive about using the donor eggs, and whether to go ahead with without doing a biopsy and all those things, we give them a free hand. We discuss with them that doing a PGT and then transferring the embryos is definitely, because it actually involves a little more of cost on them, but then we are more sure that we are putting in a chromosomally normal embryos. So we give them a free hand or free discussion. We do with them. We counsel them well. So if many people are opting to have PGT done with the embryos before we are transferring them, so it's in a way good for them also, and good on our part also, because we know that we are putting in a chromosomally normal embryo, and they are also rest assured that they'll get a healthy baby.
Healthy.
And our success rates also will be more higher with PGTA embryos.
And we can say that this is the plus point of ART fertility clinics, that they are very transparent about whatever treatment processes, procedures, techniques they are doing in handling your case. So you can just visit the center, and they have many centers across India. Just visit, get yourself diagnosed with the right doctor, and just proceed ahead with your treatment. And doctor, this is really a very good topic that you talked about, because there are much confusion related to this. Some people are like, no, I really want to go with this genetic screening, this is the only way left for me.
No,
And
there is lots of awareness though. Actually, we are
right,
happy about it. There is lots of awareness, and people do come asking for certain tests. Of course, one important thing here in our this thing is the cost, because not
conscious.
everyone is affording. So when we are suggesting for most of our patients, some might take it up and some might actually decide not to because of the cost factor also. But if you are leaving apart the cost, if you are going to ask me, by doing PGTA, are we going to get better embryos, better outcome, better pregnancies, better outcome with the babies born? My answer would be really yes, a big yes. So it is going to be an advantage to the patient in all ways, including the success rate for the procedure done also.
Right. So there's always positive thing ahead waiting for you, and we always emphasize on meeting the right doctor. So please, if you are in Chennai or you want to meet the very senior doctor on the screen, then please let us know, or you can message or call the center directly. Just don't forget to take a name fertility those when you are mentioning your issues, your concerns with the doctor. Thank you, doctor. Thank you so much for joining today. It's really very important topic to know about the genetics, and you helped us a lot in understanding this.
Thank you
Thank you.
very much. Namaste.
Namaste, ma'am. Thank you.